So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the third NeuroSTAT educational activity, our one-of-a-kind learning experience. And during this webinar, you will learn about migraine from both the clinician and biostatistician's perspective. During this episode specifically, we will discuss the real-world safety and efficacy of anti-CGRP therapy. Before introducing our first speaker, let me thank Novartis for always supporting such innovative educational activities. Our keynote speaker for tonight is Professor Dirk Krieger. Professor Dirk currently works as a consultant neurologist at Mediclinic Parkview and as a professor of neurology at Mohammed bin Rashid University in UAE. He used to be the chief neurologist and the director of stroke service at University of Zurich, Switzerland, and Mediclinic City Hospital in Dubai. Dr. Dirk holds a bachelor degree in medicine in addition to master's and doctorate in neurocritical care. He authored a number of publications in neurology disorder. Mainly his focus is stroke disease in international peer-reviewed specialized medical journal. Professor Dirk will discuss today the safety and efficacy of erenumab based on real-world evidence. Professor Dirk, you are the most welcome. The floor is yours.
Thank you very much, Maya, and thank you, Novartis, for inviting me to give this talk. I will share my screen with you.
Sure.
And off we go. This one.
Yeah.
Can you see my screen?
Yeah, perfectly.
Very good. So thank you for this nice introduction. And my topic is a short history of time in migraine. So I don't try to be Professor Hawkins, but it is a little bit about time in different perspectives in migraine management. So where is the forward? Here we go. Yeah. So we have come a long way, and I would like to point out in 1988 and 1990, the CGRP peptide, which is the trigger for our current treatments we're talking about, was discovered in Sweden, in Lund, as a matter of fact, Copenhagen and Lund. And it was then developed further into a medicine that unfortunately was toxic. And there was a publication at the end of 1999, beginning of 2000 in the New England Journal about a very effective CGRP antidote. However, it was very toxic, and it took almost another 20 years to develop the monoclonal antibodies and the GEPANTs that are now available. And as you can see here in 2008, the next development step started, and then the study started in 2013, 2018, was the first, erenumab was the first kid in the block as a CGRP receptor antibody available on the market. And we have now 5-year experience with this medication in the UAE, as well as in the United States and in Europe. So what I would like to do is to not talk about the pivotal studies that brought the approval for this medication, but the real world experience after it was introduced, so since 2019, and what patients and physicians think about it. And then I will weave in some cases at the end to give you some idea of how I would use these medications in current practice. So our experience and evidence tells us that we need to respect patient and physician time in migraine management and increase access to treatment. and in particular, the access to migraine-specific therapies. And migraine-specific therapies are those that interfere with the pathophysiological pathway of migraine, whereas the traditional medications are reducing the impact of triggers on the development of migraines. So because time is lost, we lose quality of life, family life, we lose brain. The brain is more susceptible to damage. We use freedom, we lose money, and we lose career opportunities. So this condition is, as a matter of fact, a disability. It's not a disease, it's a condition, but it needs to be managed in order to reduce the impact that it has on our lives, patients' lives. So since the medications were approved around 2018 to 2020, the published real-world experience manuscripts for Eronimab are 96, galcanezumab are 42, and firmanzumab are 38. Firmanzumab is not approved in the UAE. It is approved in Europe and as well as in the United States. The countries from which these real-world experiences come are 56 for Eronimab, 41 for galcanezumab, and 38 for firmanzumab. And in the countries in which the medication is reimbursed, there are 32 for Eronimab, 24 for galcanezumab, and 28 for firmanzumab. So would like to talk to you now about the evidence for the CGRP antibodies and what time since 2019 that we use them has taught us. So what about when we have a patient with an effective treatment? Let's say the patient has taken the CGRP monoclonal antibody against the receptor or against the CGRP for a number of months. Migraines have subsided, and then when should we pause it? Should we pause it at all? And the evidence is, my clinical experience is that if you stop the medication, at least within a year or two, the symptoms will come back. But since the migraines vary in intensity as well as frequency over time anyway, sometimes it is not immediately discovered. And so I would like to point you to the studies that have been done in a more controlled fashion. And you can see that the blue bar is the effectiveness before the amount of disability before it was used, when it was used, and when it was discontinued in red. And you can see here that it was significantly reduced in episodic migraine as well as in chronic migraine during the application of the monoclonal antibody. And after cessation, it came back to pretty much the same level than it was before, both for episodic and chronic migraine. So with other words, this is what we would expect. This is a symptomatic treatment. It's not a curative treatment. So why would we expect something else? However, we will later talk a little bit about this in the guidelines. The duration of the treatment is between 12 months and 18 months, and maybe 24 months in some other countries. And that is simply because if you do affect the migraine frequency in patients, the brain unlearns the fortification. And then after 2 years, very similar to the cessation of antidepressive treatment, sometimes the software is reprogrammed and the migraines will have subsided. But it takes a long time, and most patients do not have the patience to take the medication so long, and another problem is the insurances that have even less patients with paying for these medications because they're still very expensive. And so in the UAE, we can only prescribe them for 3 months at a time. And some patients, they think, well, this is what I get. And then they come back six months later when their migraines have turned up again, and then they'll be treated again. So what do we do with monoclonal antibodies against CGRP? How do patients perform with drug resistance migraine and chronic daily headaches? So those patients that we had a very hard time treating with these traditional trigger reducing medications, such as beta blockers, such as calcium channel blockers, such as antiepileptics or antidepressants. So the impact of CGRP monoclonal antibodies in patients with drug-resistant migraine and chronic daily headaches is shown in this study here. And it's a small study, but it shows here on the left-hand side, this is a chronic migraine patient with obviously daily headaches, so it's 30 headaches. And then after treatments, 3 months later, the headache have been reduced by 4.2 days. The monthly headache days, if you look at the monthly migraine days, those were 15, and they have been reduced those were 20, 22, 23, and they have been reduced by 4.3 days to approximately 18. And here, the need for acute medical treatment, such as in the ED or so, is also reduced significantly by minus 2.4 over the 3 months period of time. So these very complicated patients, as you can see here, are significantly reduced in this study using mostly eronimab, but also galcanezumab and frimanzumab in this study. And it clearly shows the real life experience after 3 months is a net benefit of 4.2 days, 4.3 days, and 2.4 less ED visits or use of acute medication. So what about if we switch from one CGRP monoclonal antibody to another one in non-responders? Again, there's a small study, a relatively small study done in Germany, where patients that did not respond to CGRP, most of the cases were patients treated with eronimab, and how they responded to the change to another drug, be it galcanezumab, frimanzumab, or the no, I think those were the only ones that they changed it to. And you can see it's a little complicated way to show it, but this is the 50% responder rate. So basically, patients have less than 50% migraine days. So this is effective in 3 patients, basically. And all of the other patients, the change is either less than 50%. Here it is 30%. Here is less than 30%. Here it's about 0. And then in a few patients, it is even getting more. So 32% achieved more than 30% reduction of headaches, and 12% achieved more than 50% reduction in headache days. And so it is not really a great idea to change from one CGRP to another one. If they are not responding, you want to ask yourself, is there a compliance issue, or do they need to have additional traditional medications that affect the triggers in this population? So just switching them from one to another is only effective in approximately 10-15% of cases. What does the head-to-head data with the first-line prophylactic medications tell us? So with other words, how much better do the monoclonal antibodies perform as compared to the traditional medications dealing with the triggers, and here in particular with a medication that has been used a lot and has been studied a lot, which is topiramate or Topamax. And there was a study done which was called the Hermes, a phase 4 head-to-head study of Eronimab versus topiramate, as you can see here, with a 1-to-1 randomization of 388 patients receiving, this is a blinded study, so not an open labeled study, Eronimab 70 or 140 milligrams plus a placebo versus topiramate 50 to 100 milligrams plus an Eronimab placebo. And then the treatment phase was 24 weeks, and it was basically looked at outcome in terms of how many patients discontinued, because a lot of patients seem to have discontinued topiramate over time because of side effects, because of lack of efficacy. And as you can see here, this 24-week double-blinded treatment phase was discontinued by 10.6% of the patients on Eronimab and almost 40% patients with topiramate. So, with other words, almost 90% of the patients were still on this medication, the monoclonal, as opposed to only 60% were still on it with the topiramate. So, with other words, more than 50% responder rate, which is what we're looking for, which is what the FDA looks for, what the regulators look for. How many patients have less than 50% of migraines than before? And as you can see here, these are the results. 55.4% of patients in the Eronimab group were responders of 50 or more percent, and in topiramate it was only 31%. So patients were almost 3 times more likely to reduce their monthly migraine days by 50% or more with Eronimab versus topiramate. And this data shows that it is actually much more effective than the traditional drugs, and this is one of the best ones of the traditional drugs. And that's why in the guidelines, as we will see in a few minutes, the Eronimab and also the other monoclonal antibodies are also recommended as first-line treatments in certain patients. And I will tell you later which patients I personally use it in, so that you get an idea as to how it is being used. So, changing times in migraine management. So how do our guidelines help? Well, the guidelines help us a lot because the guidelines are necessary for the third-party payers to actually pay these medications, because they're much more expensive than the traditional medications. However, they also reduce the load of disability, and they reduce the absenteeism and the presentism in these models, models of payers, and the guidelines that resolved from these considerations are seen here. First of all, these are all the studies that have been reviewed on the x-axis. So these are basically the primary and secondary studies done by the different medication producers, and then this is the risk of bias, and you can see here there's the random sequence generation, the allocation concealment, the blinding of participation, blinding of outcome, incomplete data assessment, selective reporting, and other biases. And as you can see, most of these boxes were checked with a yes, and only in a few studies here were question marks. And so we have pretty good guidelines that came out of these consideration, and we'll see here we have guidelines separate for episodic migraine and chronic migraine. And just to remember, the episodic migraine is 15 or less, 14 days or less, whereas the chronic migraine is 15 days of a month or more. And as you can see here, from these assessments that were done that I showed you before, eptinezumab, Vyepti, gets a moderate quality of evidence assessment for episodic migraine, whereas eronimab, formoterol, and galcanezumab get high quality evidence assessments for episodic migraine. And for chronic migraine, eronimab and formoterol get a moderate, whereas eptinezumab, eronimab, and formoterol and galcanezumab get a high quality of evidence. So you can see that these medications are either moderately or highly evidenced based for these indications in the European Headache Foundation guidelines. So the monoclonal antibodies targeting the CGRP pathway versus other migraine preventive treatments, and I already mentioned the Hermes study here, has gotten into the guidelines. And because this is a phase 4 study, basically, it is a blinded study. The phase 4 studies, and only one study and not two studies, as most of the primary pivotal studies were. The evidence is less robust, but you can see here there's a low evidence of quality of evidence that patients with episodic migraine and chronic migraine fare better with a monoclonal antibody than a anti-epileptic such as topiramate. So the expert consensus statement from the European Headache Federation is that in individuals with migraine who require preventive treatment, the Federation guidelines suggest monoclonal antibodies targeting the CGRP pathway, either the receptor or the CGRP itself, to be included as a first-line treatment option, which doesn't mean that it should be used in all patients, in all naive patients, but it should be used in those that either have very severe migraines or have no other comorbidities that are in favor of one of the traditional other medications, such as antidepressants or antiepileptics, as mentioned before. So not everybody should be started on a monoclonal antibody in the beginning, but it should be considered as a possibility. And in particular, in the years to come, when these medications, it's a very crowded market, where these medications become cheaper or even go off patent, then of course these medications will be used even more often. But even now, and I probably made the point before with how much of disability these medications actually produce, this disease produces, that these medications can be very effective, cost-effective in the assessment very early on. So it is now time to appraise our approach to migraine prophylaxis and look a little bit into how things are being done. And appraise is a phase 4 trial, a global pragmatic trial, 12 months prospective, randomized, active controlled phase 4 study, but open label, evaluating the long-term continued benefit of eronimab versus the oral standard of care, which was not specifically defined, in patients with episodic migraine who had failed 1 or 2 previous migraine preventatives. So this was a recorded study, and I just run you quickly through this: 100 centers in 17 countries, a screening period followed by a baseline period, then a 2-to-1 randomization as seen here, and a stratification depending on how many previous treatments were failed, 1 versus 2. And then there was a an arm with an open label arm with leronlimab 70 or 140 at the discretion of the PI, and also the standard of care or preventative at the discretion of the PI in a 2-to-1 ratio. And then there was an extension phase with leronlimab for 52 weeks with a monthly dosing. So what we can see here, which mimics the results of the Hermes study, but now in a larger randomized study, you can see that 56% of these patients reached the primary composite endpoint, which is a 50% responder rate who completed 12 months of the initially assigned treatment. So 56% of the leronlimab and only 16.8% of the standard of care. So there is a almost fourfold difference that you can see here. And then when we look at the patients that completed the trial, those were 86.9% leronlimab and only 37.5% on the other oral solutions, which mimics pretty much exactly what we saw in the Hermes studies. So there is this significant benefit that has been shown in this study as well. And then here, the secondary endpoint is the change from the baseline in cumulative average of the monthly migraine days by visit initially assigned treatment. And we can see here that this is a 12-month treatment that already spreads at the first 4 weeks significantly, gets a little bit smaller at 52, but we can see the effect of the standard care is growing over time in those patients that continued on it, but it continues to grow also, not to quite that degree, in the patients that were on leronlimab, with a approximately 50% benefit at 52 weeks in the leronlimab population. And the other secondary endpoint are the ones that were the responders as measured by a patient guided assessment. So the patients who actually found that they were doing much better, and there the difference was a little bit more significant. It was 76% of the leronlimab felt better than 80% of those that were on the standard treatment, which shows that only 2.9% of the patients with leronlimab were discontinued according to adverse events, and 23% on the other standard of care preventatives. So safety information comes from more than 2,500 patients, more than 2,600 patient years that have been treated with leronlimab in registration studies. Of these studies, the post-marketing study, more than 1,300 patients were exposed to more than 12 months and 218 patients were exposed to 5 years. The overall safety profile of leronlimab remained consistent over 5 years of long-term open-label treatment. And the reported adverse events were injection site reactions, 5.6%, so 1 in 20 for 70 milligram, and a little bit less for 140 milligrams. So about 1 in 20 has an injection site reaction. Constipation was seen in 1.3 patients of leronlimab 70% and 3.2, so 3 out of 100 in patients with the higher dose. Muscle spasms were reported in 0.1% on 70 and in 2% on 140, and pruritus on 0.7 on 70 and 1.8 on 140, and that is the real life experience, where it differs a little bit from that was reported in the pivotal studies. So most of the reactions were mild to moderate in severity, and only 2%, as I showed you before, discontinued the medication due to adverse events. So that's a very, very good safety profile. So what is the importance of time in the patient management? Well, I think this is a very important slide, and it comes out of a large epidemiological study looking at the barriers to care out of about 9,200 patients. And the first thing is the healthcare professional consultation. Here's the patients on the left with episodic migraine, and on the right-hand side is those with chronic migraine. Remind you, chronic migraine, 15 or more days of a month migraine days, and this is less than 15 days. And so you can see that only 28% of the episodic migraine patients actually do consult a healthcare professional, and 40% out of the chronics, which is clear that the chronics is even more severe, and they more likely end up in an emergency room or being referred to a neurologist or by their GPs. But you can still see that more than 50% of the chronic migraines do not even see a healthcare professional. This is not even a specialist, just a healthcare professional. So 75% of episodic migraines and more than 50% of chronic migraine patients live with this condition undiagnosed. So here, 75% then receive an accurate diagnosis when it comes to episodic migraine, and 32% when it comes to the chronic migraine when they have seen a specialist. And then 60% are being treated, and 55% are being treated of the chronic ones. And 68.2% avoid medication overuse, and 25.3% of those avoid medication overuse. What does medication overuse mean? Medication overuse is the overuse of non-steroidal anti-inflammatories, in particular brufens and Voltarens and things like that, as well as triptans. So 68% of the episodics do not have medication overuse headache, and only 25% of the chronic migraines have. So 75% do have medication overuse headache. That's a real problem, because then it becomes a mess to distinguish the migraine actually from the other headaches that these patients have, and all of these medications that they are taking in order to get rid of them. So 8.5% of the episodic patients traversed all the barriers, and only 2% of the chronic migraine patients traversed all the barriers. With other words, there's still a need for public education, as well as obviously education of the medical community with chronic and episodic migraine. So what do we lose during the migraine cycle? And as you know, the migraine cycle is a pre-ictal phase. It is an ictal phase with the headache and the most bothersome symptoms, and then the post-ictal phase, which is mostly described as a hangover or brain fog. And so the pre-ictal phase, the behavioral abnormalities in the pre-ictal phase are changes in appetite, craving for certain food. Many people say, well, whenever I eat cheese, I get a migraine, but that's only because they were craving for the cheese in the pre-ictal phase. And you can see here the associated brain activities in the limbic system, as well as in the posterior cortices that are being recorded during the pre-ictal phase. Then during the ictal phase, it is in particular in the diencephalon and in the brainstem that the activities are recorded. And in the post-ictal phase, it is distributed here in different areas of the brain, in smaller areas, and that is limited food tolerance and feeling high or low. So the migraine is a sequential event. It is a software flaw. It has nothing to do with a hardware problem, and it is divided into a pre-ictal, an ictal, and a post-ictal phase. And all of these together may last a few hours or a few days. And depending on how often the migraines follow upon each other, you can say how many migraine days these patients have, or how many headache days they have, and how many patients have actually a status migrainosus, where they never end either a pre-ictal from a post-ictal phase or ictal phase. So they have continuous changes in their daily life. And that is very, very bothersome and very traumatic to these patients. So the interictal burden that is between the ictal phases, that is the pre-ictal and the post-ictal phase, is a cognitive domain, is a interictal photosensitivity, is an interictal osmophobia, and is an overall reduced interictal impact of quality of life. And these parameters have been measured as an interictal burden of migraine and have been introduced into the models that are being reviewed to make these medications, in particular the specific migraine medications, available for those patients with those very high interictal burdens reduced daily living quality. So the social determinants of health, they include friends, community, how we interact with them at the workplace, the absenteeism and presentism, how we react with our surroundings, the housing, money and resources that are being put in and taken out, education and skills, our food intake and transportation. And then you can see here that patients over their life, in particular when they're not treated effectively, develop a low frequency migraine that then gets into a more high frequency migraine and then a chronic migraine, mainly because of the addition of the medication overuse headache. And you cannot really distinguish between the actual peaks anymore, and you have this interictal burden. And so it becomes a chronic mess. And so by treating these patients early on and by identifying them early on, you'll be able to reduce the burden of disability and reduction of quality of life with effective medication. And then the effective medication, and this is what I want to finish up my presentation with, is when we have a low frequency migraine, and I usually use one migraine per week or less, I would like to deal with the migraine one by one. And how do I do this? I do this pharmacologically, and I do this non-pharmacologically. So if I have a patient who has 4 or less migraines a month, I use triptans. I don't use ergotamines because they're not available in my country and they're not being used very much more. But the triptans are derivatives from the ergotamines. And there's another group here which is not mentioned, which is the ditan. There's only one available. Those are derivatives of the ergotamines, and those are being used in patients with acute migraines as abortive therapy very early in the preictal phase. And I deal with these patients always then when we have 4 or less migraines a day. So basically, in this phase here, in the low frequency episodic migraine phase, we deal with the migraine one by one. And we can also use neuroleptics, NSAIDs and gepants. Gepants are oral derivatives of the CGRP antagonists, and so the neurolepticas are used for patients with most bothersome symptoms, and so do the non-steroidals. And the gepants are being used very similar to the triptans and ditans in the acute phase if the migraine is a low frequency. So the prevention with either medications that affect the triggers, such as oral antihypertensives, antidepressants, anticonvulsants, botulinum toxin, or the CGRP specific medications and peptide blockers and the gepants, I use them when I have patients with 4 or more migraines per month. However, if some of them are so severe that they bring the patients out of commission for like 3 or 4 days, then those are the ones where I would also primarily indicate them. And so this is my basically patient presentation, kind of so that you get an idea of when I use it. And then the non-pharmacological interventions, which should always go in hand with the pharmacological intervention, are psychological treatments such as CBT, biofeedback, relaxation therapies, things like acupuncture, things like mindfulness treatment, lifestyle changes, in particular to address the triggers, that is sleeping regular, that is dieting regular, that is hydrating regular, that is reducing triggers and stress, aerobic exercises, particular supplements and vitamins. I would mention magnesium here in particular. And then new, mainly devices, they look at neuromodulation. And there we have TMS devices, we have various devices, including the vagal nerve stimulation that can be used, the ERN, the trigeminal occipital stimulation, and acupuncture. So all of these things together, it is very important to use non-pharmacological and pharmacological measures that fit together, because you only want to say to the patient that, you know, I provide the medication and you provide the non-pharmacological interventions, and whatever you choose to do, you do, and then we meet in the middle. And so you do 50%, we do 50%, and that is the most effective and best way forward to treat acutely and preventatively, to get rid of this migraine in most of the patients. So with having said all that, I thank you for your attention, and I'm happy to answer a few questions. Thank you.
Thank you, Dr. Dirk, for a very comprehensive and excellent presentation. So we have many questions, and I would like to encourage all our attendees to ask their question for Professor Dirk. Take advantage of his presence with us and ask you all your questions now, because the next session will be about the biostatistics of observational studies, and will not be able to discuss migraine from the clinical perspective. So the first question for you, Professor Dirk, is erinumab safe to be used in pregnancy?
No, it's not. We don't use these medications in pregnancy. Pregnancy, just to round it up, in pregnancy, migraines don't happen very often, but they do. I had a patient actually today, and because it is so rare, I actually looked it up myself, what is best being done. First thing that is recommended is magnesium. So high doses, you can give as much magnesium as needed until the patient develops soft stool, for example. So magnesium is certainly one. The next one would be paracetamol. Then you can consider aspirin, or you can consider a non-steroidal anti-inflammatory such as Voltfast. And I have also found some evidence for people to use the triptans, in particular sumatriptan, because it has been along for the longest time. And what I sometimes consider, and I did actually consider it today in my patient, because the migraine was predominantly on the left side, what you can do is you can do a occipital nerve block, which has the tendency to reduce the ipsilateral migraine. And so in this situation, I could have used a left-sided occipital nerve block, but the patient decided to further monitor and go on with medications and magnesium.
Yeah. Another question: how do we treat a status migrainosus?
A status migrainosus is the situation that I explained to you. Is a little blurry. We don't know exactly, is it the migraine? We don't know exactly which phase of the migraine is it, or is it medication overuse? Often these patients benefit from a short course of a higher dose steroid, such as I use dexamethasone 2 to 4 milligrams a day for 3 days, and that usually breaks the cycle. And then you can start with either you give an anti-epileptic intravenously, so to reach a high level early on, which is usually depakine that I use. Some people use Keppra, but I use depakine, valproic acid. And you can also use the Gepants, because the Gepants are acute migraine, abortive migraine medication. So if you start a Gepant such as Ubervi or the Pfizer one. I'm just blanking the name right now, but anyway, you can use either of them. Nurtec, so Nurtec or Embry, and you use them initially, and then you follow up with the prevention. Usually in abscess migrainosus, I use monoclonal antibodies, and there is a benefit, a potential benefit for the Vyepti, the eptinezumab, because it is intravenously applicated, and it works within hours, whereas the others have about 24 hours lead time. But so you start probably with a steroid, you consider an anti-epileptic IV, and then you use a CGRP.
How healthcare professionals other than physicians like pharmacists, nurses, and allied healthcare professionals create awareness or support in raising awareness among patients about medication overuse and migraine?
Specifically, but the overuse is not a problem anymore, because if you treat the patients with a preventative, they will only overuse it for another 24 to 48 hours max, and then they don't need it anymore. And so the medication overuse has never been a problem. The medication overuse was a real problem in the times of the traditional migraine trigger medications, as I call them, because they were not very effective. And so the patient used a lot of triptans, a lot of non-steroidals, and they had these very blurry headaches. But since we have the CGRPs, in particular the monoclonal antibody prevention, medication overuse headache is not a problem anymore.
What about the use of antihypertensive, the traditional treatment, the beta blocker and the ARB in the treatment of migraine? Do we have comparative efficacy among these molecules? Which one is better and is more effective?
Yeah, we do have, I pointed out to you the antiepileptics, which have been studied because they have been the ones that were used mainly, and we had most of the data on them, because the antihypertensives, particularly propranolol, the data is very old, and it doesn't really compare with the current FDA requirements anymore. So, but anyway, to answer your question, if there is a comorbidity, for example, you have a patient with a depression or anxiety and migraine, it makes a lot of sense to start them on amitriptyline, for example, and see how they respond. And a lot of them do respond very well to the migraine and the comorbidity. So if somebody has hypertension, of course I use an antihypertensive. But it's a little bit like in the old days, and I want to use this example, with syphilis and sulfasan. As soon as penicillin became available, it was almost a crime to use the non-specific medications. It's a little bit different here because this is not a disease, this is a condition. But I think we will see within the next 5-6 years that these medications will be used as or embraced as much as the oral anticoagulants has been embraced in the times of the Coumadins. It takes 5 years because there is money involved, there is traditions involved, there is pathways involved, and these pathways need to be slowly dismantled. But I have no doubt that within the next 5 years we will not see a lot of these non-specific trigger medications anymore, unless you have comorbidities or specific allergies or any other condition.
Another question, how can we manage episodic migraine if it came without aura?
That's a good question. It's very tough. The problem is that you don't really have the time to use a ditan or a triptan. So this is actually an indication, depending on the severity of the migraine, for prevention or for the use of a gepant. So let's say this happens, it's a female disease, 3-1. So many cases, they prevail around the menstruation. And so sometimes these patients that don't have the premonition phase, they just end up in out of the blue headaches. They at least know, well, it happens when I have my menstruation. So you have the chance to use a gepant the day before you enter your menstruation, and then you'd use another one the day after, in the case of Ubelry, or every other day in the case of Nurtec. So you can do this over the period of your menstruation and then be done. But it depends a little bit on how the case presents itself. If you have random occurrence of out of the blue migraines, then you will have to use some kind of a prevention, because the triptans and the ditans won't work.
Yeah, thank you, Professor Dirk. So another question. So now we have many anti-CGRPs. We have oral ones, we have many subcutaneous option, and we have the IV molecule. So if a hospital pharmacy want to choose among all these anti-CGRP to be added to the hospital formulary, which one would you choose to be added?
Well, as I showed, they are pretty, at least the monoclonals are pretty equivalent, yeah? So the efficacy is very comparable. The safety profile is very good. So there's no, you can, if you have to, you can choose one, yeah? So you would choose the one that gives you the best price as the pharmacist.
Yeah.
The differences between them is, the one that you can choose IV is for 3 months, and some patients, they want this. Others, they want to be in charge themselves, and they go for the EpiPen ones. In terms of the orals, I think, should be considered the modern triptans and ditans, because they will eventually replace those. And so you will have to have them available in addition to the monoclonal. And I have a lot of patients, for example, who, they take, let's say, Eronimab, and then, shortly before they get their next injection, the migraines sort of creep up again. And for those women who have very, very strong menstruation-related migraines, maybe there's some migraine equivalence left, during the time of the migraine. And for those situations, you can spice them up with an oral gepant. And the other issue, which I haven't dwelled upon, but you probably all remember, in particular, this is for chronic migraines, there's botulinum toxin. And botulinum toxin is sometimes used in addition to Eronimab or Galcanezumab or the others in very, very severe cases. And I have a few patients that are treated with Botox plus monoclonal antibodies, simply because the Botox reduces a trigger, which is mainly the cervicalgia that these patients have, and the tension headache that ends up in a migraine. And also the botulinum toxin has a small but significant anti-CGRP effect. So you can combine them.
Yeah. So since, Doctor, you mentioned the combination, what about, do you have data about, and we receive this question in every migraine webinar, but I need your expertise here about combining anti-CGRPs together?
You mean the ones from the same class?
Yeah.
I don't.
Do we have data about combining, for example, oral sub-Q in refractory migraine cases, of course?
Yeah, oral, the gepants, the oral, the small molecules, I would combine them with any of the monoclonals as a sort of spice up if there's a breakthrough migraine. Yeah, but to combine, let's say, 2 monoclonal antibodies, I have not even thought about it. I haven't done it, because in real life, they're very effective, and changing them one for another is only effective in about 1 in 10 cases, and combining them has not been done, simply because nobody would pay for it. And what I have done is I have increased the doses in some. So, for example, when Eronimab became available in the double dose for the same price as the smaller dose, I have changed my practice to only use the higher dose because the complications are very, very low. And when it comes to eptinezumab, Vyepti, which the dose is 100, sometimes a higher dose is more effective, and sometimes you use a higher dose, the same higher dose as you would use in cluster headache, for example, for galcanezumab, and also for eptinezumab. So yes, you can increase the doses, but I haven't combined monoclonal antibodies, but I have combined gepants with monoclonal antibodies. Does that make sense?
Yeah. Another question. So with the COVID-19 pandemic, there was, and after now this pandemic, there are increase in the frequency of episodic migraine headache and all type of pain or migraine headache. So with these types of conditions, so COVID-19 or post-COVID-19 headache or migraine, how do we manage these types of headache? Is it the same management?
Yeah, it is the same management. This may vary a little bit from country to country, but here in the UAE, we have stopped wearing masks. I don't remember, 9 months ago or something like that. So everything went back to normal, at least beginning of this year. And so, yes, there is still a few patients who are saying, well, my migraines started when I had my COVID and things like that. But I'm not really convinced that has anything to do with it. I treat my patients now the same way as I treated them before the pandemic. And during the pandemic, obviously, we had lesser access to our patients because they were all locked up.
Virtual follow-ups.
Yeah.
A final question, I guess this is the final question about constipation. So constipation was among the common side effect in clinical trial for Erenumab. What about from your experience, real-world experience in Erenumab, is it a common side effect of this medication?
It's not. It has been. When the first study that came out was the Eronimab study, and everybody said, wow, this is amazing. What is the downside? And we were looking at this table. I think everybody has looked at this table in the New England Journal, and it turned out, yes, constipation is the only one that really significantly differs between the placebo and the Eronimab group. And so we always focused on this. I think it's a little bit of a bias that we introduce. In my practice, I have seen it only in a handful of cases. But to be honest, if you have a patient that suffers from significant constipation, Eronimab would not be my first choice because you have other options. And with the other medications, the constipation has not been found as significantly different when it comes to the side profile. So when it comes to Eronimab, I use it a lot because it is very straightforward. It's a receptor antagonist and not a substrate antagonist. But when it comes to patients with known bowel disease and things like that, I shy away from it. But it actually is not a big pool of patients.
Yeah. This is the final question, and apologies, but we received many questions for you. Is there any serious drug-drug interaction between Erenumab and other medications?
I'm not aware of them, no.
Okay.
Oh, it's not.
So those were all the questions for you, Dr. Dirk. Thank you so much for joining us tonight, despite your busy schedule. And thank you for this excellent presentation. Thank you so much, and looking forward to host you again in another webinar. Thank you so much.
Thank you, Maya. Bye-bye.
Bye-bye. And now we will move to the second lecture with Dr. Hani Dimasi. So our biostatistician, Dr. Dimasi is currently an associate professor of biostatistics at the Lebanese American University since 2012. With a PhD in biostatistics and an MPH in epidemiology, Dr. Dimasi taught in multiple disciplines, nursing, pharmacy, biology, medicine, and at different levels and in different setups. He also provided researcher in a variety of health-related fields with statistical as well as methodological and research design support. So Dr. Dimasi today will teach all of us about how to conduct observational study in order to get this real-world data discussed by Professor Dirk. Dr. Dimasi, you are always the most welcome. The floor is yours.
Thank you, Maya. Thank you for the invitation. Thank you again for having me. It's a pleasure to be here. So today, we're going to talk a little bit about logistic regression. Maybe because logistic regression is one of the most widely used method of multivariable analysis in observational and in other type of designs. So I will try to give you an overview of how it works. I'm not going to go into the technicalities and the formulas of it. I will try to make it as much as applicable, but at the same time, it has to be something related to statistics. So I thought it would be interesting if we start with the idea that, let's imagine I have a set of patients that maybe they're suffering from migraine and I'm looking at their quality of life. I measured their quality of life and I have the score I've tabulated here. And the next thing I would like to do is maybe to have a graphical display. So I'll put them on the axis, checking where every point, every value is showing on the axis of the quality of life. Then the next thing I do is I'll rotate the data and I put them on the y-axis. You know, they're staggered one on top of the other, showing their place on the quality of life scale. So far, so good. The next thing we like to do is introduce another variable, which is, in this case, is mental health. And let's suppose as mental health score increases, then you have a better mental health. And if you look at the data, it seems that these two are kind of working together. They're going up together. And it would be interesting to see how much the mental health score is actually playing a role in the quality of life. So we can do that graphically by introducing the quality of life as the mental health on the x-axis, keeping the quality of life on the y-axis. And then your dots now start to scatter across the graph. And you have a nice scatter plot, obviously showing a trend where as mental health increases, it seems that the quality of life of this patient is increasing as well. One thing that statisticians like to do, and I think most of us would like to do as well, is try to fit a line that best describe the relationship between mental health and quality of life. So that line is called the simple linear regression line. And basically, it's trying to find the best association fit for these points so that I can try and explain how much quality of life is related to mental health. And typically, you're going to get a line form like this, where your quality of life is going to be on the left side. And then there is a formula that is trying to explain how this quality of life relates to the mental health. And so when you do that, you're going to get this general line form, where typically the outcome, the dependent variable, the thing that we're trying to explain, we will refer to it as y. And then you can write it as B0 plus B1 x1. And basically what that means, B0 is the intercept, meaning as x reaches 0, where would the line be? And you can see that if you go all the way down with the line, you can see that the line is going to intercept somewhere here. below 0, but just before -2. And actually, that value is -1.05. The next part of the equation is B1 times X1. X1 is your independent variable, your exposure, your exploratory variable. This is the variable that we put on the x-axis. And this is the variable that is trying to explain to us what is happening to y. And attached to this x is going to be B1. And B1 is referred to as the slope of the line. And the best interpretation for that slope is by how much our outcome variable is going to change for every unit change in the independent variable. And graphically, you can imagine if you take, for example, 0.1, and you can extrapolate it to the line, and you can see that the y is going to be 2 point something, and then increase the 1 to 2, go back to the line, try to extrapolate it, you see that you are around 7. That increase in the y is actually the 4.57. That is the slope. That is what is happening to y as x increases 1 unit. And the slope can be positive if the line is going up. It could be negative if the line is going down, or it could be 0 if actually there is no line at all. Okay, now this is nice, and this actually works as long as your y variable is numerical, as the case is in this example I was going over. But however, many times in research, the outcome of interest is not numerical. Many times we're interested in a binary outcome, something that comes as yes, no. So for example, where the patient cured, it's either yes or no. Is the patient after surgery dead or alive? So it's 2 options. Was the patient hospitalized or not? Is the patient taking medication? Is the patient depressed? Is the stroke occurred? And many, many, many more examples. Many research actually have interest in an outcome that we call as binary, meaning yes or no. Well, in that situation, if I would like to repeat what I just did, I will get something like this. So again, imagine 10 patients, 6 of them are cured, and I will represent the status of being cured with a value 1, and 4 were not cured, and we represent their status with 0. If I want to do what I did a minute ago, if I want to plot their status on the y-axis, well, I'm not going to get much distribution. All I'm going to see is overlaying 6 points on the 1 and overlaying 4 points on the 0. Okay. And if I try to continue what I did a minute ago, if I introduce the mental health score, and so the mental health score is going from 0.25 to 3.8. And as you can look at what is happening to the mental score and their status, well, you're not going to get this beautiful scatter plot that we had a minute ago. All you're going to see is few points that are flat on the 0 and few points that are flat on the 1. And therefore, we're not able to try to fit this line that we fit a minute ago. The line that we fit a minute ago, which was, we called the simple linear regression. And so that was a problem for a statistician because they really wanted to find a way to mimic what was done in the linear regression because it has so many attractive attributes that we would like to replicate. So the solution came using a transformation. So basically what happened is we do a transformation going from the binary outcome being yes or no, changing that into a probability of being cured. And let me remind everybody that the probability is a formula, which is A over A plus B. Meaning if I want to use the cure example, it's the number of cured divided by everybody, by the total, okay? And that probability, you can then change it into an odd of the outcome. And the odd of the outcome is written as A over B, not A over A plus B this time. يعني the number of cured على number not cured. And that changes a little bit the distribution of the probability. It expands it a little bit. So a probability's space is between 0 and 1 with a lot of value possible between 0 and 1. And then if you turn it into an odds, the space becomes from 0 to very, very big values, infinity. But that's not the only thing we do. We take the odds and we turn it into the log of odds by taking the natural log of this odds that we just calculated. Now, this thing that we just calculate, we call it the logit. And that's where the name logistic regression comes from. It's because we're going to use this logit. What that logit has is the value of being continuous, going from negative infinity to positive infinity. And by now, you can imagine that we kind of solved the issue of only having 0 and 1. Now you have a variety of value going from all the way from negative infinity to positive infinity. So let me show you how it actually works. So imagine the probability. As we said, a probability goes from 0 to 1. 0 meaning there were no cured, none was cured. And as you go to 1, everybody was cured. Now, if you change this probability, and I have values ranging from 0 to 1, from very, very small, all the way up to 50%, and then up to 1%. If you change that into an odds, and the formula, there is a formula, which is, it's this probability divided by 1 minus that probability. You get starting having the odds, and you can see that the odds goes from 0, as I said a minute ago, but it doesn't stop at 1. Actually, a probability of 50% will give you an odd of 1, and then will extend all the way to infinity. So you kind of have half of the solution. But then when you turn this odds into the natural log of it, yani the logit, what happened is this 0 to 1 will expand from negative infinity to 0. And then the rest from 1 to infinity will expand as well from 0 to infinity. And now I have an outcome value expanding from negative infinity to infinity. And then I can carry on my work the way we did previously, where we're going to take the logit and we're going to work with it like we did with the linear regression. The form is back to where we were a minute ago. I'm going to call it y prime just to differentiate from regular y, which is your original variable, cured yes or no. So y prime is the logit, but the rest of the formula is exactly the same. You have your beta 0, you have your beta 1, and then you have your independent variable. Okay? So again, beta 0 this time is still your intercept, but the interpretation of this intercept, this is where your x1 is equal to 0. So beta 0 is the value of the log of the odds of being cured when x1 is equal to 0. And the slope works exactly the same way we talked about a minute ago, but you're not talking about the change in y, rather it's the change in the log of the odds of y. Now, maybe you're saying, well, this is too complicated. What is the log of y and what does it mean? Don't worry about it. We're going to make it easy to interpret in a minute, okay? So here's an example. I have in this table 46 patients, and let's suppose that they're either cured or not cured. And they also either have a low mental health or a high mental health. And you can see that the numbers are split to show exactly who is who in this table. If we're going to calculate the odds of being cured in this group, the low mental health, well, according to the formula that we covered a minute ago, you're going to get all those that were cured, the 14. And remember, we're only looking at those. You're going to get the 14 and you're going to divide by the 22. Okay, not by the 36, by the 22. And that gives you an odds of being cured for the low of 0.6363. You change that into the logit, it will be negative 0.452. Now, if you move to the other group, high, and on high mental health, and again, you try to calculate the odds of being cured, well, 32 got cured in this group, divided by those that were not cured, yani 32 over 18, you get 1.77. Okay, and you change that into a logit or the log odds, the value is 0.575. Okay, well, if we go back to the definition we had a minute ago about how the line works, you remember we said that the intercept is going to be the log of cured when x, hey, the x here, is 0. And that was negative 0.452. The slope is going to be how much this logit is going to change as x is moving from 0 to 1. So the logit changed from negative 0.452 to 0.575. That change is equal to 1.027. And this is going to be the beta 1. So just by drawing a 2x2 table, knowing how to calculate your odds and knowing how to turn them into logit, you can easily create your logistic regression like this. I did not stop there. I tried to test it on a statistical software called SPSS. So over here, you can see I turned my table into SPSS. I ran the logistic regression. First of all, I double-checked that the table SPSS produces is exactly the table I had shown you a minute ago, and it is. And then as you run the logistic regression, you will get this. This is the intercept, and this is the slope, exactly as we predicted. So it's working perfectly fine. All right, so all of this is wonderful, but we're working in the logit space. How do I make sense of it? Well, you make sense of it by coming back from the logit space to the usual space. And it happens that if you do that, it turns out that the slope, this beta, if you come back from the natural log and if you exponentiate, you know, going the reverse of taking the natural log is the exponential. So if I take the exponential of the slope, it will produce an odds ratio. An odds ratio is a measure of association that we like and we know how to interpret and we know how to use. So this odds ratio is going to be the odds of the outcome being present, so the odds of cured if x is 1, over the odds of being cured if x is 0. And in our example, this is the odds of cured for mental health being high over the odds of being cured for mental health is low. And sure enough, if I take the odds that I calculated previously and I divide it by the other odds, I get 2.79. At the same time, if I were to take the slope and if I were to exponentiate it, I also get 2.79. So what that means is that I can actually take the slope, I can exponentiate it, it will give me an odds ratio. An odds ratio is a measure that is very easy to interpret. So let's review how we interpret an odds ratio. If you get an odds ratio of 2.9, this means the odds of getting cured for the mental health high is 2.79 times higher than if the mental health is low. So obviously you're seeing an increase in the odds of getting cured. And you notice that I'm very picky about the words I choose. I say odds, I don't say risk, because we're not calculating a risk ratio, we're calculating an odds ratio. If you get an odds ratio of 1.8, you can speak of 80% increase in the odds of the outcome, whatever your outcome is, as the independent variable increases by 1. So now you notice that I'm giving a more general definition of an odds ratio. So going from 0 to 1, when you have high mental health, low mental health, actually works even if your independent variable, your X variable, is something like age. Then the interpretation will be, this is how much the odds of cured is going to change for every 1 year increase in the age of the patient. What if I get an odds ratio that is of 0.75? Then an easy way to interpret it, you can say that 25% decrease in the odds of the outcome is occurring as the dependent variable is increasing by 1. So a general rule of interpretation of an odds ratio. If an odds ratio is 1, it means there is no association between X and Y. Again, I'm using X here to note the independent variable, your exposure, Y to note your dependent variable or your outcome. Mind you, it has to be binary. Your outcome has to be binary. Okay, so if your odds ratio is 1, there is no association. No matter what happened to X, it will not impact Y. If your odds ratio is greater than 1, this indicates a positive association between X and Y. It means as X increases, the odds of Y occurring also increases. Okay, so X could be binary as well, as long as you code it correctly. You get a 0 and 1, like the example I gave. It could be men and women. So as long as you know who gets to be coded 0 and who gets to be coded 1, who gets to be coded 1 and 2, it doesn't matter. If you code it correct, the interpretation will hold. If your odds ratio is less than 1, it indicates a negative association between X and Y, yani between your exposure and your outcome. Yani as X increases, the odds of Y becoming 1, yani the odds of the occurrence of the outcome decreases. So I'm going to show you a little bit more of example to try to make sense of the interpretation of the odds ratio. So again, we're going with the Y being cured, and it's binary. So it's either cured or not cured. And over here, I have an example if the X is binary, yani present or absent, or if it's numerical. The first example I have for you, if the odds ratio is equal to 1, for example, X binary for gender, male and female. Well, if X is equal, if the odds ratio is equal to 1, yani there is no relationship between gender and being cured. So I say the odds of becoming cured is the same for men and women. There is no association between gender and becoming cured. If X is numerical, for example, age, and still the odds ratio is 1, well, same thing. The odds of becoming cured is the same for every 1 year increase in age. Yani age and being cured are independent. Age does not affect the likelihood of being cured. What if the odds ratio is greater than 1? Example 1.8. Let's suppose X is being treated. How would I interpret this 1.8? Well, I would say the odds of becoming cured is 80% higher among the treated versus the non-treated. This 80% is coming from the fact that 1.8 is higher than 1 by 0.8. You turn it into 80%. Now, what if X is numerical, like social support score? You say for every unit increase in social support, the odds of becoming cured increases 1.8. Yani, does that mean if social support unit 1, and then I have another person with 2 points social support, and then I have a third person with 3 points social support, then the difference in odds between 1 and 2 is the same between 2 and 3? Yes, but between 1 and 3, it's not 1.8. There is the first 1.8, and then there is the second 1.8. Let's move to the example if the odds ratio is less than 1, for example, 0.5. So let's suppose X is measuring depression or being depressed. What does it mean that the odds ratio of being cured is 0.5? This means the odds of being cured among the depressed is 50% those of not depressed. So there is a decrease in the odds of being cured among the depressed and when you compare them to the non-depressed. So that means the depressed are doing worse. What about if X is numerical? For example, the Apache score. How would I interpret a 0.5 odds ratio? Well, this means the odds of becoming cured drops by 50% for every 1 unit increase in the Apache score. As the Apache score increases from 1 to 2 to 3 to 4, every 1 unit increase is dropping the odds of being cured by 50%. All right, so let's go back to my model and the SPSS output. So what do I get when I ran a logistic regression? You get a big table like this one, and let's look at every part of it. So the first part are the betas, or also called the coefficients. These are beta 0 and beta 1, as I mentioned. And you will be able to interpret them because you have on the left showing what these are. So constant meaning the intercept, and MH is representing the mental health. With every beta, you get a standard error. The standard error is a measure of how precise is this estimate. And it will be used to test if these betas are statistically significant or not, because you must remember everything we do at the end of the day has to be tested for statistical significance, which takes me to my second point, the Wald chi-square, the degrees of freedom, and the p-value. Every coefficient, so this beta is called the coefficient, will get its own chi-square, the Wald chi-square. You see, you get 2 of them. Each one is 1 degrees of freedom because there's only 1 slope for each, and a p-value. So you can see that the beta for mental health is statistically significant. When you're testing the betas, the null hypothesis is that the betas are 0, equal to 0. So when it's statistically significant, it means the beta is different from 0. But this Wald chi-square can be also used to interpret the odds ratio, which come later on. But this time, the null hypothesis would be that the odds ratio is equal to 1, not 0. 0 is for the slope, 1 is for the odds ratio. Okay? So what this is saying is that the mental health has a coefficient that is different than 0, meaning that we have a line, we do have a line for the logit. So that takes us to the last part of the table. The last part of the table, as you can see, it says XB, yani exponential of the beta, which is actually the odds ratio. If you exponentiate 1.027, you will get the 2.79. And also a confidence interval, the 95% confidence interval, which also is another way to test if these odds ratios are statistically significant or not. So you can see that over here, my odds ratio is 2.79, and the 95% confidence interval is going from 1.15 to 6.77, not crossing 1. Again, you have to remember with odds ratios, we're testing 1. It's not crossing 1, so it is statistically significant. Now, everything I talked about so far was about the situation where I only have 1 independent variable. Yani my model only had x-axis 1. Can it be expanded? Yes, it can be expanded to have more than 1 independent variable, which takes us to something called the multivariable logistic regression. Some people call it the multivariate logistic regression. The other call it the multivariable logistic regression. And basically what that means is that my linear model is going to be expanded. I keep my logit where it is. I have, again, an intercept, but this time I have multiple independent variable, and each one of them will get its own coefficient, meaning its own slope, and each one of them, by exponentiating these slopes, will give me its own odds ratio. An odds ratio that tells me the relationship between this independent variable and the outcome. Okay. Now, the nice thing about this method is that your independent variable can be a mixture of categorical or numerical variable. So you can put here age, which is numerical. You can put gender, which is categorical. You could put education, which is not only categorical, but also multi-level. And any kind of variables, you can put them in your logistic regression. When you do that, when you put multiple variables together in one model, yani you're doing a multivariable model, what is happening for every slope is that it's going to adjust for the presence of other variables. So this slope is going to be adjusted for the presence of other variables. And you may be familiar with the concept of confounding. Many times we talk about it in research. If you're thinking that maybe, let's suppose, income could be, or social status could be a confounding variable for your outcome being cured, walala, or maybe having an insurance could be a confounding variable, then all you have to do is add it to the model. When you add it to the model, the other variables will be adjusted for their presence. And therefore you will see, I'll show you in a minute, sometimes researchers, what they do is they will report their adjusted and their unadjusted odds ratios. So adjusted odds ratios mean the odds ratios coming from this multivariable model that has all the variables, including the confounding variables. The unadjusted meaning the simple model, the model that only had this variable all by itself. And by showing you the adjusted and the unadjusted, you can see how much of a difference it made to adjust for the other variable. And therefore, researcher can reflect if these other variables are actually playing a confounding role or not. So how do people actually report the results? There are different ways. So here I'm showing you a multivariable logistic regression model. And you can see here what they decided, and this was part of a course. What the students group decided to do is to report everything. The beta, so now you know that the beta is the slope on the logit scale, the standard error for that beta, the Wald chi-square, the degrees of freedom, and the p-value. But again, when you see the exponential b, this means the odds ratios and the confidence interval, and all of them in one model. So you can see that this model had, and I think this model was looking at mortality and morbidity post-operation. So you have the gender, you have the age, you have the BMI, diabetes, smoking. So you can see a list of variables all together cramped in one model in an effort to try to understand this one outcome, which was mortality, whether present or absent. Other people report something much simpler. So again, this is coming from one of the articles. And you can see that they decided to call the beta as regression coefficient, which is completely fine because remember, a logistic regression is a regression. So these are the beta, the standard error of the beta, the p-value. This time they're not calling them the exponential of the beta, they're just calling them the odds ratios and the confidence intervals. And you can do your own calculation. You can take the coefficient, exponentiate it, and it should give you the odds ratio. One thing to note, if your betas are positive, all your odds ratios are going to be greater than 1. If your betas are negative, your odds ratios are going to be less than 1. Remember, لأنه coefficients, the value of no association is 0. Below 0, that's a negative association. Above 0, it's a positive association. But when you go to the odds ratio, the point of no association is 1. Below 1 is a negative association. Above 1 is a positive association. Some people like to represent all these odds ratios in one graph. They do some sort of a tree plot with the reference being 1, as you can see, because that's where you can tell if it's losing its significance, walala. And you will see that they're representing the odds ratios with a wiggle showing the confidence interval. And as long as you're not crossing this 1, then the odds ratios are statistically significant. Most of these are statistically significant. Maybe this one is right at where it's borderline statistically significant. Here's another main example, as I mentioned previously, of people showing their unadjusted betas and their adjusted betas. Maybe I should have shown the logit of it. I'm sorry, I made a mistake here, but it's fine. It's the same idea. You're going to say you're going to show the unadjusted odds ratios with a confidence interval and the adjusted odds ratios with confidence interval, and you're going to observe how much of a difference. So the unadjusted, meaning every variable by itself was tested alone with the outcome. And so this is one analysis, another analysis, a third analysis, كل وحدة لحالها, okay? Whereas when you go to the adjusted, you threw everything in this model together and you're reevaluating their values. Okay, so what else do we get with logistic regressions? You get a lot of things and there's no time to go over everything. I'm going to focus on three things that are pretty important, that I think are important to understand and to interpret the logistic regression. The first is called the log likelihood. The second is one type of test of goodness of fit, which is the Hausman-Lemma show. And then I'm going to conclude with looking at the predicted probabilities and how you can use these to draw an RSE curve with an area under the curve. So let's start with the log likelihood. A lot of time they refer to it as LL. Some softwares, they report it as -2LL. So basically what you're doing is you're calculating a likelihood of all your values. Without going into the details, what you're doing is you have this line that we drew on the logit scale. You have this line. You're going to go on the line for every value that you had, and you're going to extrapolate it to your Y scale, turn it into a probability and multiply them. And basically, if your model is a good model, then the probability of predicting the outcome should be high, should be 1. And remember, if you turn 1 into logit, then it will be very small. So what that means, if you don't want to know all the details, all that means is that good models produce smaller LL, log likelihood. The smaller your log likelihood, the better your model. So one thing softwares do is they're going to produce 2 log likelihood. One without your predictor, without your X, this is called the base log likelihood, or the no model. I call it the no model. There's nothing helping you trying to predict. And then it's going to also look at, once you introduce this X, hoping that you were able to drop that likelihood. The more you drop it, this LL, the better it is. And by comparing how much you were able to drop it, you will be able to test if your model is actually is significant model. So a very, very simple formula is you take the -2 likelihood of the one model minus then the second model. So for example, you can put the null model here and the model here. That produces a chi-square with degrees of freedom, and that will give you a p-value, and therefore you will be testing if your model is helping you interpret your outcome. So here's an example. You can see that it's producing the log likelihood, and then it's showing you the change in the negative. So the -2, it's because we need to do that to get a chi-square. So it tells you how much you were able to drop that, and then this has a chi-square distribution, and it gets a p-value. And long story short, if you're running a logistic regression, the smaller your log likelihood gets, it's better. If you're comparing 2 models You can look at how much you were able to drop the log likelihood. That is a chi-square. You can test it. If it's statistically significant, it means that the model or the next model is better than the previous one. All right. What else do we get with logistic regression? Well, you can get something called goodness of fit. A goodness of fit is a method to check if your data fits your model well. The null hypothesis in these techniques is not that the data doesn't fit, that actually the data does fit the model. What that means is that you do not want to reject the null hypothesis. So whenever you're checking a goodness of fit, like the Hosmer-Lemma show, you want your p-value to be not significant. If it's significant, it means that your data is not actually fitting the model. Your model is not working well. And here I have an example of the Hosmer-Lemma show. And this example shows that the chi-square for the Hosmer-Lemma show came out to be very statistically significant, meaning that in that specific example, the model is not doing well at all. And you can tell by looking at, so this is the group that did not have the outcome, and this is the group that had the outcome. And you can see what is happening is you're looking at the observed data versus the expected data, meaning how much your model was able to match the observed data. And if we go to the yes part, you can see that there is a lot of discrepancy. It's not doing well at all. So here we're observing 2, but we're predicting about 5. Here we're observing 12, but we're predicting about 10. And so that discrepancy creates a bad goodness of fit. A good goodness of fit, your observed and your expected would be kind of similar to one another. There won't be a much difference between the two. So another thing that you can get from your logistic regression, you can ask your software for every individual person that you have in your data to calculate a predicted probability of having the outcome. So let's suppose your data had 500 participants. You were trying to predict if they were cured or not. You've created your logistic regression. You checked if it's statistically significant. You looked at the slope. You looked at the log likelihood, etc. You can ask the software, please calculate a probability for each of these 500 individuals if they were cured or not. And then your probability is going to be between 0 and 1, obviously. So one thing statisticians like to do is they like to take this predicted probability and find a cut point. And they say, okay, like anything above 50% chance of being cured, we're going to be considered that this person is cured. And anything below 50%, we're going to be considered that person not to be cured. And by doing so, they can start calculating sensitivity and specificity. So let me show you an example of that. So let's suppose I have this set of data. This is my observed outcome. So some people have the outcome, like they were cured. Some people were not cured. My model produced these probabilities. Okay. And I'm using cut point of 50%. So anything above 50%, I'm going to say, I'm going to predict that this outcome here is actually occurring. And anything below that 50%, I'm going to predict that the outcome is not occurring. So now you can calculate specific sensitivity, which is the probability of the predicted being 1 if the observed is 1. And in that case is 3 out of the 5. So out of the 5 that actually had the outcome, I was able to correctly predict 3. So that's 60% sensitivity. Then I do the specificity. The specificity is the probability of the predicted being 0 if the observed is 0. And I'm predicting that they are not cured if in reality they're not cured. I have 9 that were not cured, and I was able to correctly classify. This is why this technique is called the classification. So I was able to correctly classify 6 of the 9, which is 67%. So using a cut point of 50%, my model produces a sensitivity of 60% and a specificity of 67%. Now, what happened is that you can change that cut point from 50% to 40%, and you go back and you reevaluate your sensitivity and specificity. And as you note, one goes up, so the sensitivity went up, but that means that the specificity went down. Okay, so we keep changing that cut point and looking at sensitivity and specificity till we have all possible sensitivity and specificity. We take this data and we plot it. So we plot it where on the y-axis, we plot the sensitivity. On the x-axis, we plot the 1 minus specificity. And you can see that it goes from 0 to 1 here and 0 to 1. So you can imagine that there is a square right here. And as you're plotting your data, so this is an example where the ROC curve is giving this blue line. Generally speaking, the closest your blue line is to this corner, the better. It means that your model is good as classifying your outcome. And then, so remember, this is a square, a 1 by 1. So the area of the square is 1. And you try to calculate the area below the blue line. So all of this, okay? The closest you are to this corner, the higher the area under the curve is going to be. Yani it will be about 0.9, 0.99. For this specific curve, the area under the curve came out to be 0.774. This is also called the C statistic, which is also many times reported in logistic regression, trying to say how good this model is. And the C statistics come with its own standard error, with a p-value and a confidence interval. A rule of thumb, if you're hitting a 0.7 and above, that's a good C statistic. You also have this green line, because that green line is your basic null hypothesis. You know, if you start getting close to the green line, which is about 50% of the area, it means your model is not doing anything better than chance. So with that concludes most of the things I want to talk to you about the logistic regression. One might ask, well, why did you take the log of the odds? Why don't you take the log of the probability itself? This is possible. This model is called the probit model. And if you look in the literature, you would see that a lot of people do that. But you have to be careful, because your design has to allow for calculation of that. The good thing about the logit, meaning using the odds ratios, is that all designs allow the calculation of the odds ratio, whether it's an observational design, a cross-sectional, a case control, a cohort, an RCT, it doesn't matter. Whatever you're doing, you can do the logit and therefore do a logistic regression. Are there other modeling technique? Yes, of course. You have the hazard ratio technique with the Cox proportionate model for the survival analysis. Poisson modeling is used for the annuals relapse rate, for example, among many, many other techniques. So in conclusion, logistic regression was a good replacement to be able to do a regression without having to do the linear regression. It works whenever your outcome is binary, yes and no, but you have to go to the logarithmic scale. Once your model is created, you exponentiate these slopes, and that gives you an odds ratio that you can interpret easily. But you have to remember that you have to check for statistical significance, either with the p-value or the confidence interval. And then to evaluate how good your model is, you can look at your log likelihood, you can look at your Hausman-Lemma show goodness of fit, and the C statistic. So in conclusion, I would like to thank again Maya Zainuddin for inviting me, the IVPN, NeuroPsychiatry, and Novartis for this wonderful opportunity to talk to all of you. Thank you.
Thank you, Dr. Dimasi, for a wonderful presentation and a very enriching one that we all needed it. So allow me please to take some questions. So the first question, how do I determine what statistical test to use for variable in a CE study?
Usually there are guidance on what tests to use. And what I usually say is that you ask a few questions. You ask how many groups you want to compare. And also you ask if these are matched groups or not. So are they the same people, repeated measures, or they're completely independent? And then you ask, what are you comparing them? Are you comparing them with regard to a categorical variable, like cured or not cured, or are you comparing them with regard to a numerical variable, for example, quality of life? By answering all these questions, it becomes very easy to check which test you're going to use. So whether you're going to use a chi-square or an independent t-test or an ANOVA, etc. Now, all of these tests I mentioned are what we call the bivariate analysis, meaning that you're only looking at one variable by the outcome at a time. Once you want to start looking at multiple things at the time, we move into the multivariable, which includes the multivariable logistic regression, linear regression, etc.
What is more robust, the hazard ratio or the odds ratio?
Well, the good news is you don't have to choose between the two. The hazard ratio is used when you're having a survival analysis. The odds ratio is used when you have an observational study. So if the scenario of your study is a survival, meaning that you're following up people to a point in time where the outcome occurred, and you're interested in how long it takes before it occurred. And typically this is what happens in survival analysis. You know, you may have two groups, both of them are being treated. And within 10 years, unfortunately, everybody is, you know, if it's overall survival, everybody's going to die. So the question is, you're really looking how fast is the outcome occurring. Then in that scenario, you're going to go with the hazard ratio model. Now, the logistic regression and the Cox proportional model, they each have a requirement that I didn't touch on because I didn't complicate things. You need to make sure that you're meeting the basic requirement assumptions.
Yeah. And a final question, do you think that the logistic regression should always replace the linear regression in observational studies?
So that kind of resembled the previous question. Again, if your outcome is numerical, then you don't have to do logistic regression. If your outcome is quality of life, if there is some sort of a score, then you just go with the linear regression. Now, sometimes researchers start asking the question, well, I can categorize an outcome, you know, maybe quality of life, I can cut it so that it becomes good quality of life, bad quality of life. This is a research decision that you have to make with your research team, and maybe with looking at literature, looking at what has been published. And once you make a decision, stick to it and go with it till the end.
And ask a biostatistician always, and
well, yeah,
have
can.
on board the opinion of a biostatistician or an epidemiologist or the expert in the field. So with this, our webinar comes to its end. Thank you, Dr. Dimasi, for a really very enriching presentation as always. And now our third NeuroSTAT webinar, as I mentioned, comes to its end. Thank you for our esteemed speaker, Professor Dirk and Dr. Dimasi, for joining us. Thank you, Novartis, for supporting this educational activity. And the big thank you, as always, goes for you, our attendees, our almost 500 plus attendees, and for staying with us until the end of the webinar. I would like to remind you all that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of Dr. Dimasi or Professor Dirk presentation, and you would like to revisit the lectures, you can always visit our IVPN library, which is currently available free of charge, where all the recording will be posted also within 10 days of today. Finally, follow us on our social media platforms and stay tuned for more neurostatistics series, and also for more educational activity in the neuropsychiatry field. I would like to announce our next activity, which is scheduled this Thursday on June 15, and which will also be sponsored by Novartis. And it will be targeting nurse nurses and pharmacists specialized or interested in the field of neurology, and it will discuss update about multiple sclerosis for nurses and pharmacists. And what is special about this educational activity that it will be endorsed by the Consortium of Multiple Sclerosis Center in USA, and you receive certificate of attendance from the Consortium of Multiple Sclerosis Centers in USA. And the other activity for this month will be on Friday, June 16, and we'll discuss treatment-resistant depression. So stay tuned for more detail that will be shared on our social media platform starting tonight. Until we meet again, stay safe and have a good night.